So coming to the liver tumor as of now. So liver tumor is the fourth most common cancer worldwide. In the US, it is the most common cancer causing death. So around 90% of the hepatocellular carcinomas. So it is followed by other rare variants of the liver tumors like intrahepatic cholangiocarcinoma and then childhood hepatoblastomas and fibrolamellar HCC. So out of liver tumors, it is hepatocellular carcinoma, which is the most common, and it is the fourth common cancer worldwide, and it is the most common cancer as of now with very high mortality. So, what are all the risk factors for liver tumor? So, as we all know, decompensated liver disease. This could be viral, infective, or a non-infective. So, among the infective, hepatitis B and hepatitis C, which has an annual risk of 3 to 8% per year transformation of liver cirrhosis into HCC. And what are all the other causes? Ethanol induced, alcohol, non alcoholic steatohepatitis or this NAFLD, and other rare metabolic disorders like Wilson's and hemochromatosis. So, compared with the most common cause, it is the virus which has a very high annual risk of 3 to 8 percentage, followed by the other causes like alcohol, NASH, or the metabolic liver disease. So, if any question comes, which of the following etiology has the highest risk of transformation of liver cirrhosis into hepatocellular carcinoma? It is the virus, followed by the other causes, and it is high male predominance. So, a few points about the viruses. So, hepatitis B virus, 60% goes for HCC. Hepatitis C virus, it is 30% risk of HCC. Why? Because now hepatitis C virus is as well as a slow indolent course, and we have an excellent treatment for HCV virus, which can help in reducing the risk of transformation of liver cirrhosis into HCC reduction, as well as it reduces the risk of death due to decompensation. That's why now the hepatitis C virus has a less prediction for going into HCC. So, what are all the predisposing factors for hepatitis B? IHBV viral DNA, which is indirectly reflected by IHBE antigen positivity. So, these two directly proportionate to the risk of hepatocellular carcinoma. And the genotype C variant of hepatitis B virus has an high risk of HCC transformation. Similarly, coming to HCV, it is type 1b genotype, presence of advanced fibrosis. We use this histological classification called as a Metavir classification, which is F3, fibrosis grade 3, and cirrhosis. So when HCV patient have advanced liver fibrosis and cirrhosis, they have risk of development into HCC. So compared to alcohol metabolic liver disease, which has less prediction, and try to remember this gene. This has been asked once in the exam, and with gene polymorphism is associated with conversion of NASH liver disease into hepatocellular carcinoma without cirrhosis. So normally what we'll see chronic liver disease, liver cirrhosis, decompensated and hepatocellular carcinoma. Whereas in NASH, patient with fatty liver can directly go into hepatocellular carcinoma without being developed into liver cirrhosis. That is because of this gene, PNPLA3. So PNPLA3 polymorphism in NASH is associated with high risk of transformation into HCC. Aflatoxin fungus, we know TP53 mutation causing hepatocellular carcinoma. Some basic pathology we should. Low grade dysplastic. Whenever there is a malignancy, we always have dysplasia. In HCC, we have low grade dysplastic nodules, which transform into high grade dysplastic nodules. And HCC is a high inflammatory condition. High inflammatory cytokines plays an important role in genetic modifications of cancers. So, as common with other cancers, see growth factors, signaling pathways, BRAF mutations. These are all only rarely mutated. This is the most important because no much targeted therapy available for HCC because we don't express growth factors, we don't express secondary signaling pathways like MEK inhibitor or RAS pathways, we don't have BRAF or we don't have ER2. That's why these mutations are rarely mutated in HCC, so thereby we have less targeted agents for HCC. So just remember these two genes. How hepatitis B integrates into TERT cyclic event is the cell cycle progression and MLL4. Hepatitis C and alcohol have a CT-double-N-B1 integrase. So these are all the point of cell cycle integration, which helps in converting the cirrhosis into an hepatocellular carcinoma. Remember this alone. So which molecular aberration is the core in HCC? It is TERT. TERT, as we read once in our diskeratosis congenita. TERT and diskeratosis congenita gene DKC. So these TERT and all telomerase stability. What are telomerase? Telomerase are present at the end of the chromosome, which helps in preventing the cell senescence, cell death, because telomere CC TAG. So CCTTAG. So this is the sequence of the telomere which helps in preventing cells from senescence. When this enzyme is deficient, cells won't have telomere, so thereby cells undergo early senescence. So TERT promoter is most commonly affected in hepatocellular carcinoma, followed by the other mutations. So TERT overexpression is seen in 90%, TP 53 alterations are seen in hepatitis B virus, and then WNT beta catenin pathway is abnormal in 50% of cases, and VEGF is an important mediator of angiogenesis, which helps in increasing the tumor size also in metastasis. A key signaling pathway in disease progression is HCC. That's why we have VEGF inhibitors in the management of a metastatic HCCs.